Today's show is sponsored by Strawberry.me. As nurses and future nurses, so much of what we do revolves around solving problems. So that when it comes time to focus that attention on ourselves, it can sometimes feel overwhelming. I've recently felt so overcommitted and like my days just spiral out of control. So I decided to try something new. I decided to try personal coaching with Strawberry.me. It has been so incredibly eye-opening. My coach Anne asks me such great questions and helps me focus on what really matters. She's not telling me what I should do. She's helping me discover what is going to help me reach my goals. With Anne's help, I've set up consistent routines and daily habits that have made a huge difference in my overall well-being and help me feel like I'm finally back in control of my days. With Strawberry.me, you're connected with a coach who's perfect for you, often in as little as 4 hours. And I love that Anne checks in with me periodically to see how I'm doing. It's a great motivator and reminder of the goals I've worked toward. Visit strawberry.me/nursemo. That's strawberry.me/nursemo and take charge of your future with the help of a certified coach. And get a $50 credit when you sign up at strawberry.me/nursemo. Well, hello there. I'm Nurse Mo, and this is the Straight A Nursing Podcast, where I share tips and advice to help you thrive in school and at the bedside. So if you've been listening to this podcast for any length of time, you know that I always like to start out with a listener shout out, and I'm going to be completely honest with you. Somebody commented that my listener shout outs were, I think the words they used were annoying and cheesy. And I think I've mentioned this before because I wasn't sure if I was going to keep doing them. And what usually happens is I'll get one person who tells me that they hate the way I'm doing something. And I think, wow, everybody must hate that. I need to change it immediately. But I let this one simmer for a little bit. And this person had a valid point. They're like, well, I'm already listening to the podcast. Obviously, I like it. I don't need you telling me how much other people like it. But I started thinking about it a little bit. And a couple reasons I want to keep doing the listener shout outs. One, if you're brand new to this podcast and you're hearing it for the very first time, I think it's great that you hear the value that other people get out of it, either out of my podcast or other programs that I offer. And then secondly, I've heard from so many people who get excited because they've heard their shout out, heard their name on the podcast, and heard me share their words. So the positives way outweigh being a little cheesy, being a little annoying. Hey, I'll own it. I am cheesy. Maybe I am a little annoying, but I'm doing so because I'm celebrating you, the listener, and I'm celebrating all the nursing students and nurses who are taking extra steps to be even more amazing. So this listener shout out goes out to all of you. And if it's not your jam, you know what? Just fast forward. Just fast forward. I do it all the time on podcasts. Just skip ahead to the good stuff. So now let's hop into the good stuff. And today we are talking about airway management, which I get it. Airway management can be incredibly, incredibly scary. When I started work as a brand new nurse in the ICU, it really wasn't that big of a deal because most of our patients were intubated. So their airway was managed. Check box on that one, right? That thing is taken care of. But when I started working in the recovery room in the PACU, airway management became a huge part of what I did. And at first, I was a little bit scary. And I know it can be scary for anyone who's just learning about it and getting used to being kind of comfortable with it for the first time. So that's what we're going to be talking about today. So when would you need to actually manage a patient's airway? And when I say manage an airway, I mean you're keeping the airway open. So you may have to do this if you've got a patient who is sedated. Maybe they're a little over sedated. They're still ventilating, they're still breathing, but they're occluding their airway. Now, the first time I had to deal with this, I was an ICU nurse, and I had taken a patient down to interventional radiology for a procedure. They gave him 50 of fentanyl, or probably 50 of fentanyl and a little Versed. And guess what happened? He started occluding his airway, and his sats just started dropping. And initially, it was a little terrifying because, again, ICU nurse, everybody's intubated. I didn't have a ton of experience with airway management, but just doing simple maneuvers is all it took to get this gentleman's sats back up. So that was kind of the first time I really saw the power of effective airway management in action. So that's one key way you could need to manage an airway. Your patient is sedated, still ventilating, but they're occluding their airway. Another very common scenario is your patients who are recovering from anesthesia, which I do all the time as a recovery room nurse, or just your basic BLS. You've got an obtunded or unresponsive patient. What's the A and ABCs? It's airway, absolutely. You also want to maintain airway patency while you're ventilating a patient with a bag valve mask. And you can also use an airway opening maneuver to confirm apnea. So if your patient's not, sats aren't coming up or they're dropping and you're not sure, are they completely apneic, like having no respiratory effort, or are they occluding, you could open the airway and see. If you open the airway and there's no air movement, you've definitely got bigger problems. This patient needs more than just an open airway. They also need ventilation in addition to that. So those are kind of the situations in which you will need to be managing your patient's airway. So now you might be asking, well, why does an airway need to be managed? Why do these airway obstructions occur? So when I'm talking about airway obstructions here, I'm not talking about your foreign body getting into the airway. I'm talking about that super common situation in the clinical setting where there is a soft tissue obstruction. And this occurs due to prolapse of the tongue into that posterior pharynx and also from loss of muscular tone in the soft palate. As a nurse working in the recovery room where I worked for several years, the most common reason was because of anesthesia and sedating medications such as opioids or benzodiazepines, or that combination of opioids and benzodiazepines. And I can tell you, I have held many an airway as a PACU nurse. And like I said, started out kind of scary and then did it so much it quickly became pretty much a routine part of my job in that setting. So what we're going to be talking about and diving into more here is, what are the signs that your patient is obstructing and could potentially need their airway opened? What is the optimal position for an airway? We'll talk about manual holds and we'll talk about airway adjuncts. So let's start by talking about signs that your patient is obstructing. So basically, key sign here is sound. Do you hear abnormal sounds? And the key sound you're going to hear is a snoring sound. This would be the sign of a partial obstruction. Now, if your patient has that snoring sound, they would benefit from their airway being opened. They still have some air movement, but they would benefit from optimal air movement. So doing some things to position the patient, which we'll talk about in just a moment, to maintain a nice patent open airway. But there could also be no sound, and there would be no sound if the obstruction was total. So with a total or complete obstruction, the patient is trying to move air. You'll see their chest moving, maybe some accessory muscle use. You might see the abdomen getting involved, but there's no air movement. There's nothing coming in and out of the nose or mouth, and that means there's nothing coming in and out of the lungs. So when your patient has a total obstruction, you got to get on this right away. If we're not taking care of these things very quickly, you could even see cyanosis, which would be another sign that your patient is obstructing. And that's going to occur, pretty close to the point where they actually go into full-on arrest. So we don't want them to get to that point where they're cyanotic. So let's say you've noticed that your patient is obstructing either partially or completely. What are we going to do about it? And if you know me, you know I like simplifying things so that they're easy to understand and easy to remember. So I have a 3-part approach to this, and it's face up, chin up, and bottoms up. So let's talk about face up first. And this is optimal positioning for your patient. And the optimal position that we want our patient in is called sniffing position. And when the patient is in sniffing position, this means the external auditory canal is on the same horizontal line as the sternal notch. Now, because everyone's anatomy is different, you may need to do some maneuvering, and in some cases, a lot of maneuvering, to get the patient into this optimal position. So a lot of times, this could mean putting a pillow or folded blankets underneath the head or the neck or the shoulders. You want to get, again, that external auditory canal in line with the sternal notch. You want them on the same horizontal plane. And I know this is difficult to describe on audio, so I will have some pictures on the Straight A Nursing website. Go to straightanursingstudent.com/airway to get a look at those. Now, sometimes sniffing position could be enough to open that airway, but not always. But we want to start there. So get them into that sniffing position. Now, getting the patient into sniffing position, let's say you've got an infant. Sniffing position could be achieved by placing padding behind the shoulders in an infant. And that's because they have a big occiput. So if you looked at a diagram of an infant laying on their back, their occiput's pretty big, so it kind of tips their face forward. If we put a folded blanket or folded towel or something like that underneath the shoulders, this helps push that plane of the face horizontal with the ceiling, and we have the external auditory canal in line with the sternal notch. In a larger patient, so you have an adult patient who's quite large, you may need to do a lot of elevation underneath the head, the neck, the shoulders to get their ear or the external auditory canal in line with the sternal notch. And as you put the patient into this position, you'll notice that the plane of the face is now horizontal with the ceiling. So that's why I call it face up. Again, for visual, you can check this out on the Straight A Nursing website and get like an idea of what I'm talking about if you're having a hard time making that mental leap from audio into visual in your mind. Alrighty, so we've talked about optimal positioning, face up, getting the external auditory canal in line with the sternal notch. We're going to use pillows or folded blankets, a rolled up towel, whatever we need to get the patient into that position. Now, let's say we do that. Maybe it helps a little bit, but it's probably not always going to help completely. Now we're looking at a manual hold, and there are 2 types of manual airway holds. We can do the head tilt chin lift, or we can do the jaw thrust maneuver. Let's first talk about head tilt chin lift. Now, the first thing I want you to know about the head tilt chin lift is that it is contraindicated in patients who have suspected or confirmed cervical spine trauma. And yes, this includes cervical spine surgery. So if you're in clinical or you're working in the inpatient setting and you have a patient who just had surgery on their cervical spine and they're occluding their airway, you're not going to be going for a head tilt chin lift on this patient. It can cause further injury to the spinal cord. Definitely don't want that. So let's say we've ruled it out. Our patient does not have cervical spine injury. So we're going to go ahead with our head tilt chin lift. To do this maneuver, very simple. Push down on the forehead with one hand, and this tilts the patient's head back. That's the head tilt part. And then with the other hand, use the tips of the first 2 fingers to pull up on the mandible. That is the chin lift part. Be very careful as you're doing this to avoid the soft tissue of the neck, because anytime you're pushing on that soft tissue of the neck, you could worsen an obstruction. Now, this maneuver lifts the tongue away from the posterior pharynx and, ta-da, opens the airway. So this is the chin up part of my three-pronged approach, which was face up, chin up, and bottoms up. So now let's talk about bottoms up, and this is with the jaw thrust maneuver. So if your patient has that cervical spine injury, you're going to skip head tilt chin lift, go to a jaw thrust maneuver, okay? And if the head tilt chin lift in your patient doesn't quite get an open airway, then you could try a jaw thrust maneuver. Sometimes we just go straight to a jaw thrust maneuver. It's really what you're comfortable with and what is best for the patient. So in order to do a jaw thrust maneuver, you're going to stand at the head of the bed, even though you will see people trying to do it from the side of the bed. That's really bad ergonomics. It's going to be very difficult to do. You want to be at the head of the bed and place your palms on the patient's temples and then your fingers under the mandible. Again, be very careful you're not pressing on the soft tissue here. And then you just simply lift the mandible upward with your fingers. And you want to watch for the lower incisors, those bottom teeth, rising up above the upper teeth, and that's why I call it bottoms up. As you are doing this maneuver, be careful that you're not extending the neck in your cervical spine injury patients. You want to be very, very careful that you're not manipulating the neck as you perform this maneuver. And then, once you have your open airway, you simply maintain your manual hold, whether you're doing head tilt chin lift or jaw thrust maneuver, and you hold on to that until the patient is able to keep their own airway open. In many cases, this will be once that over-sedating medication has worn off, or maybe they got a reversal agent, or if the patient has recovered enough to maintain their own airway. Let's take a quick break, and when we come back, we'll talk about airway adjunct devices.
Nordstrom brings you the season's most wanted brands. Skims, Mango, Free People, and Princess Polly, all under $100. From trending sneakers to beauty must-haves, we've curated the styles you'll wear on repeat this spring. Free shipping, free returns, and in-store pickup make it easier than ever. Shop now in stores and at Nordstrom.com.
So next we have airway adjunct devices, and this is the OPA and the NPA. You will see some uses of LMAs. We're not going to talk about that here. We're going to talk about your basics, OPA and NPA. Now, an OPA is an oropharyngeal airway, and an NPA is a nasopharyngeal airway. So when would you use these devices? Well, in some cases, manual maneuvers like the head tilt chin lift and the jaw thrust maneuver may not be enough to keep that airway patent. In this case, you got to go for a device, an OPA or an NPA. I've seen patients come out with 2 NPAs and an OPA after surgery, whatever it takes. Another instance is when you're holding the airway for a long time. Maybe the patient got a lot of medication in surgery, and it's going to be a bit before they can maintain their own airway. You can switch from a manual hold to an adjunct device and at least be able to perform your other assessments, look at their dressings and their drains, and do some documentation. You just never, ever, ever want to leave the patient's side when they have an adjunct airway in place. Another time you may want to consider using an adjunct airway is if you are manually bagging a patient. An OPA or an NPA is going to do a really good job of maintaining that patent airway. A better job, I would say, than a manual hold does, and that's because with manual bagging, it is possible to push down on the chin as you work to keep that really good seal on the mask. And if you're pushing down on the chin, you're not doing a chin lift, right? You're not going to keep that airway nice and open. So let's start by talking about OPAs. The key thing to know about this device is that it is only used on an unconscious patient who has no gag reflex. You would never, ever, ever use this on a patient with a gag reflex, as it can cause vomiting and aspiration. So to use an OPA, it's actually pretty darn simple. The key thing is that you want to choose the appropriate size. So to size an OPA, and if you're working in a clinical setting, there's probably, in the PACU, for example, where I worked for several years, there was a box and it had a bunch of different sizes of OPAs. So you go to the OPA box, or it's the OPA and NPA box, and get the size that you need. So get a size that you think might work, maybe get a couple on either side of that, and you want to place it against the side of the patient's face. And what you're looking for is for the flange of that device. You place it at the corner of the mouth, and the end of the device should reach to the angle of the mandible. So corner of the mouth to the angle of the mandible. If it's too short or too long, grab a different device and measure again. If your OPA is too short, it's not going to help your obstruction. It could actually make it worse. And if it's too long, it can be very irritating and cause a laryngospasm, which is an airway emergency. Now, before inserting the OPA, let's clear that oral cavity of any secretions or vomitus or whatever could be in there. And we may need to add some lubricating jelly to that OPA device, especially if the mouth and tongue are really dry. So let's say you're in an outpatient or inpatient surgery setting and the patients are coming to you after surgery and the mouth may be really dry because patients are NPO prior to their procedure, so they're pretty dehydrated. And a very common medication that is given in surgery to reverse anesthetic agents does cause dry mouth as a side effect. So the mouth could be dry, put a little lubricating jelly on there. Now there are 3 ways to insert an OPA. The main and most common method is to place it in the mouth with the curved end towards the roof of the mouth. And then as you advance it and the device nears the posterior pharynx, you rotate the device 180 degrees into the correct position so that that tip is pointing down. Be careful as you do this that you're not scraping against the roof of the mouth or the hard palate. There can be some trauma with that. Now, another option to avoid that is to use a tongue blade to press the tongue down as you insert the OPA in that position with the curve pointing down. So depressing the tongue with the tongue blade, and you push it in with the tip pointing down, or that curved end pointing down. Now, a third option is to point the tip towards the corner of the mouth and rotate 90 degrees as the device is advanced to the posterior pharynx. Most often, you will see the first method used where it's basically inserted upside down and then turned 180 degrees into that curved end down position. Now, once inserted, the flange should rest at the patient's lip, and you want to keep a really close eye on this device to ensure it does not become dislodged, because if it does, guess what? You lost your airway. And you also want to make sure that you're keeping a very close eye on your patient. As they wake up, that gag reflex is going to kick in, and they will want that device out ASAP. So be ready with gloves and a tissue nearby so you can get it out before they gag and possibly vomit and possibly aspirate. Now, some contraindications for an OPA are, number 1, a patient with a gag reflex. Hint, if your patient can cough, they have a gag reflex. A patient with oral trauma. Obviously, a patient with a wired jaw is not going to get an OPA. And if the patient has oral trismus, which includes spasms of the oral musculature. It's also contraindicated if the patient has a foreign body obstructing the airway. All right, so that is the OPA. Next is the NPA, or the nasopharyngeal airway. Now, this is a great device to use if your patient has a gag reflex, but is still occluding the airway. I see this type of device used a lot with our patients after surgery. They'll wake up, so they have a cough, they have a gag, but then they go back to sleep and they start occluding. But they'll wake up and they'll be fine, but then they get drowsy and they fall asleep again and they start occluding. They're not totally unresponsive and they are not without a gag reflex. So I would not put an OPA in this patient. What I would want to reach for, though, is an NPA, which is a great device for keeping the airway open in a more responsive patient. Now, to measure your NPA device, you're looking at two things. One is a bit more important than the other, but you are looking at two things: width, or the diameter, and the length. So the diameter of the device should be just slightly smaller than the nair. Okay, so just slightly smaller than the nostril. As for length, you're going to measure from the nair to the earlobe. That's nair to earlobe. If it's too short, it's not going to be effective. And if it's too long, it will either enter the larynx and cause gagging, or it will enter the vallecula, which could potentially cause an airway obstruction, and we definitely don't want that. Now, if you have to choose between length or diameter, length is going to be the more important measurement, so get as close as you can to that diameter measurement as you're choosing your NPA. Now it's time to insert the device. We're going to get some lubricating jelly on there, makes it a lot more pleasant for the patient and reduces nasal trauma. And we're going to point the bevel towards the septum and follow the floor of the nasal cavity as the device is advanced. If you meet resistance, do not force it. We definitely don't want that. Withdraw and try on the other side. So there you have it, your quick overview of airway management. Hopefully now you don't feel as nervous about it. You feel like, if my patient's occluding, I could get in there and do something about it, because guess what? You absolutely can. So I hope to see you back here again in a few days when I pop into your podcast feed with Mo's Monday Minute, which is my quick little tip that I share on Mondays. And if you find this podcast helpful, I would love if you would rate and review on whatever podcast platform you listen to. And if you're listening on Spotify, you can even shoot me a message, send a comment to through that platform, and I will see that as well. So thanks again for listening, and I will see you back here again soon. Bye for now. This podcast is brought to you by Straight A Nursing, a proud member of the Airway Media Network. For more educational podcasts, check out airwavemedia.com. And for more nursing-related content, go to straightanursingstudent.com.
Hey everyone, it's Dan Souza from America's Test Kitchen. I'm super excited to let you all know that we're launching a new video podcast that takes you behind the scenes into the messy, imperfect, but riveting day-to-day life right here in our test kitchen. Not only do I get to talk to my colleagues about the latest taste test they attended.
I just came from a tasting of salted caramel apple pie bars and then roasted garlic, so I apologize.
Or about a recipe they're developing.
The thing about this recipe is it's a secret. The restaurateur refuses to tell people what her secret ingredients are.
We also chat with amazing guests from the culinary world and beyond.
The lamest joke I've ever said. I said to Marie Bamford.
Great.
It's
Definitely
great.
said worse.
Thanks.
Make sure to subscribe to In the Test Kitchen so you don't miss an episode. You can watch In the Test Kitchen on YouTube and Spotify and listen to it wherever you get your podcasts. Can't wait to see you in the Test Kitchen.